Well, good afternoon, everyone. I'd like to welcome you to this special seminar jointly organised by University of New South Wales's School of Population Health and the Kirby Institute. I'm John Kaldor, Professor of Epidemiology at the Kirby Institute. Before starting the seminar, I'd like to acknowledge the traditional owners of the land where I am, which is the Arakwal people up in northern New South Wales, and the place known in the Arakwal language as Cavanbar, and also acknowledge traditional owners around the country from all the places where you're joining us from, and pay respect to all Aboriginal people who are joining us today. So our topic today is mathematical modelling in relation to the COVID pandemic. Mathematical modelers have been around for a long time in health, but it's probably fair to say that they have, in many circumstances, been more behind the scenes than up front. Now, with COVID, they've become almost as popular with the media as epidemiologists seem to have become, and their work, which maybe in the past might have been primarily seen in academic journals, at least for the large part of it, have now been taken very seriously in real time by government policymakers. And the output of their work has certainly influenced a number of the decisions that we've been facing as a country and at the jurisdictional level in COVID. Today, we're going to hear from not just one, but 5 mathematical modelers who've been heavily involved in the COVID response. We have 3 presenters from the University of New South Wales. We have 2 discussants from the University of Melbourne. Well, I'll introduce them all in a second. We're also, I think, honoured to be joined by Professor Andrew Wilson from the University of Sydney, who's also currently working with the Ministry of Health in New South Wales. So we have 3 presenters from the University of New South Wales who will start this session and present the work that they've been doing supporting the COVID response in New South Wales. And then we'll hand over to get some comments from our 3 discussants. And then after that, we'd really like to hear from you as the audience. Any questions you may have, both for the main presenters and for the discussants, and any issue you'd like to hear feedback from any of our key panelists. So the 3 presenters from the University of New South Wales, first of all, we'll have Associate Professor James Wood, who's trained as an applied mathematician, is with the School of Population Health, and for the past 15 years has been using modelling to inform infectious disease policy and control, particularly focusing on vaccines. Dr. Deborah Cromer leads the Infection Epidemiology and Policy Analytics Group at the Kirby Institute, and she's been also very active during the COVID pandemic, engaged in epidemiological modelling work at the national level, and also supporting research that's been crucial at an international level about understanding vaccine efficacy. And the third speaker will be Dr. Nic Rebuli, who completed his PhD recently in mathematical epidemiology at the University of Adelaide, and has been working since 2020 between the School of Population Health and the Kirby Institute on modelling for vaccination and transmission. I'm going to hand over to James Wood, who's going to give a bit of an overview of the modelling work supporting the New South Wales Ministry of Health, and then he'll pass on to the other 2 speakers. So thanks very much, and over to you, James.
All right, thanks everyone. So I'm speaking today from Gadigal land. I'm actually on campus at UNSW Sydney for the first time in 3.5 months. And I also want to pay my respects to traditional custodians of this land and sort of my acknowledgements to Aboriginal people in the audience today. Thank you for joining. So I'm going to give an overview. As John said, we're all on a bit of a tight schedule, so I am going to run through this relatively quickly. And I will start by talking about kind of the work we've done over the last 1.5 years with New South Wales Health, but with a major focus on, I guess, the recent work on vaccination rollouts. And then I'll pass to Deb to talk about work on mobility and how this informed some of our analysis. And then Nic Rebuli is going to talk more about agent-based models and projections in his presentation. So just to start out, we're not doing this in isolation. It's been a big group of people assisting, us, and I want to give thanks to them at the outset before, in case we forget in the rush. So particularly Professor Nick Golding and his team from Curtin, who've been instrumental in the sort of transmission potential approach that we used to work out the effects of vaccination on transmission in New South Wales. Nick and Deb, you're going to hear from in turn, but Chip and Duan also works with me, and then Eva Stadler did a lot of the work on mobility, and we've had a lot of input from Richard Gray, John Kaldor, David Regan and Ben Huey in terms of review of our techniques internally, and then from the University of Melbourne, Cam Zakreeson, Nick Geard, Freya Shearer, you'll hear from at the end, and David Price. Freya and David particularly have been helping us with occupancy forecasts. And also, finally, a big thanks to many New South Wales Health staff who've offered us review, provided us with data sets in timely fashion, and it's been a really good relationship. So just to kind of start us off, we've been providing support informally to New South Wales Health since about March 2020 in various periods. And I guess the initial part of this, when we had the first wave in 2020, was looking at case and ICU forecasting. I'll talk about that very briefly in a minute. We then sort of moved on to trying to understand, the effects of contact tracing and, the public health restrictions that we were using successfully last year to contain transmission. And this was kind of a collaborative approach in the sense that we had to develop, what we thought were the data requirements for this. And simultaneously, New South Wales Health was actually putting together data sets that would answer these kinds of questions. And so that sort of occupied us really over about a 1-year period prior to the Delta outbreak. But so from mid-June to late July, we did some work on case mobility data, and then from late July, we've been contracted with New South Wales Health to look at targeted vaccination programs, particularly in the LGAs of concern, to look at the utility of the case mobility data to monitor how the restrictions were working and TTIQ was working, and then more recently projections of the epidemic, occupancy, and the effects of reopening. And I'm not going to say too much about the latter parts here. I'll allow Nick to talk a bit more about that, but I'll make some general comments at the end of my presentation. So I guess the early learnings we had, and ones which I think everyone who's been involved with this has learned at some point, is forecasting when RT is uncertain is challenging. And particularly when you know that there are future changes occurring due to interventions, you really need to contextualize your quantitative results and sort of give policymakers sort of the additional insight that you have about what's coming beyond what your quantitative model is predicting. And I guess to give an example of that, in about a 10-day period from late March to early April in 2020, our projections of occupancy in ICU went from this enormous range from 300 to 7,000 down to 30 to 45 as the effects of the wave 1 lockdown on transmission became apparent in case data. And so one of the big challenges is you're always working somewhat behind what's going on with transmission, and RT less than 1 is control and RT greater than 1 is an epidemic, and you've got massive differences in what can occur if you don't know which side of the line you're on. And so I guess an early learning of this was to unpack this for decision makers, but I guess it also, for us and other groups, influenced the need to, A, can we get more and better data, and B, how do we sort of take account of the other sort of measures we have, including from overseas settings or of effects on mobility, to parameterize expected future effects of structural change. So refinements to data and models basically occurred from this. So, and that kind of motivated these sort of desire to try to look at, the restrictions we'd been using, the effects of contact tracing, the sorts of capacity constraints and other measures that were used in New South Wales successfully in the second half of 2020. And we were defining our minimum data to try to assess these issues. And as I mentioned earlier, New South Wales Health was developing an enhanced sort of data set looking at cases and contacts that captured a lot of this sort of information. And this was a bit of an iterative process, but by December 2020, there was data available to sort of look at or what's happening with transmission by exposure site, different classes of exposure sites. What do we see in terms of mean behavior and variance, super spreading events and so on. And Nic can talk a little bit more about that. And it also offered the ability to get a sense of the effects that contact tracing were having on transmission in terms of identifying delays from being exposed to being isolated, and therefore being able to capture the amount of your infectious periods spent in the community. And we were sort of, I guess, our focus was to kind of turn this into scientific publications as of about May and early June this year, when suddenly the Delta wave hit. And I guess we made the immediate decision to switch to decision support and look at, I guess, what we could contribute in terms of advice and analysis in relation to outbreak control. So I guess just, how did the Delta outbreak change things for us? I mean, I think this is reasonably well documented in the public domain, but just to kind of say it in a few short slides, in general, it's about twice as transmissible as the ancestral strains that we saw last year. There's very likely a shorter incubation period. And, those changes may not sound huge on an individual level. It sounds significant, but not necessarily huge. But one of the big things they did was they made the exposure sites that were previously not likely to generate onward transmission, so suddenly no longer safe and likely to generate, growing chains of transmission. And households became a site of dissemination even in lockdown. So you might have completely linked your cases, but you were still seeing onward transmission from these households because you don't get to them in time. And so by late July, we had a fairly clear idea of what the RT estimate was. It was pretty consistently 1.1 to 1.2, implying a growing epidemic trajectory, fairly slow, but still growing, despite the strict lockdown. And then you run into concerns about, well, how much can contact tracing continue to scale as your cases and tests rise? And what else can we do? I mean, you can think about really, really strict lockdowns, more draconian measures, but those are going to be very, very disruptive to life and economically extremely damaging. We also had a growing vaccine supply at this time. Could targeted vaccination play a role? Okay, and so I guess this sort of question, what can targeted vaccination do? I mean, we had at that time, still a geographically focused epidemic in the sense that it was in a number of, a large population in Sydney, but it was reasonably contained to that population. And we knew that transmission, the risks of sort of introduction of cases to household, the source cases skewed young. We had very low uptake at that time in younger people because of the nature of our programs. And so it was a question of, could we, if we targeted a one-dose program at younger adults in LGAs of concern, could this, bring forward the sort of reduction in transmission required to bring RT less than 1 and see our epidemic start to turn around? And I guess basically over a few hours, I did a back of the envelope calculation that looked promising for this. Don't worry too much about this sort of graph on the right here, but we were essentially, the y-axis is the expected reduction in transmission due to vaccines, and the x-axis is the weeks after you change strategy. And I suppose we were looking at within a 2 to 5 week period, a big change in transmission potentially as a result of this strategy. Now, at that time, we couldn't get extra doses, but a couple of weeks later, the extra supply from Poland arrived that could be then used to support a program such as this. And I guess just to kind of, before I get into a little bit more of our analysis of this, I just want to kind of note what we sort of were observing was happening with contact tracing. So we were seeing that things like the time from onset to isolation, this left-hand panel here, in household or other contexts, was remaining fairly stable. In fact, it improved since the beginning of July. But that aspects such as the time from a specimen being taken to being confirmed, so notification, and from confirmation to a full case interview, we're starting to blow out in terms of time because of the amount of tests that were occurring and the amount of cases that people were having to follow up. So we were starting to see a loss of the additional kind of advantage you get from contact tracing of sort of getting ahead of transmission. Okay. And so that, those concerns were legitimate that contact tracing might be starting to do less well. So a very quick run through, I'm already at 11 minutes, so I've got to speed up, of how we approach the effects of vaccination. So we had fairly good data from the UK that looked at the effects of vaccine efficacy against infection and infectiousness. Not perfect data, but certainly we had estimates of both these things from decent studies, and that has continued to improve. That data has continued to improve over time. And those pieces of information combined with vaccine coverage could be used to estimate the change in your RT, or we use this concept of a transmission potential, which is an estimate of the reproduction number at a sort of an area level. And there's differences between the two, because when you've got outbreaks going on, outbreaks always sort of find the populations that are higher risk for transmission, but the average behavior in a population of, say, an LGA size is described by these transmission potentials. And one of the things we were sort of aware of was that, the relative changes in transmission potentials should flow through to relative changes in RT. So we could kind of look at how our projected transmission potentials were changing in time and sort of estimate when we might expect to bring even the most concerning LGAs in terms of transmission to an RT value below 1. And the primary thing we looked at was targeted vaccination of 16 to 39-year-old age group in the LGAs of concern in Sydney. And when I say completed, that program started in mid-August, but we'd provided our advice on the program by mid-August. And the scenarios we ran at that time assumed that second doses were delayed to October. Now we've seen that as supplies opened up, a lot of coverage projections have been brought forward in the sense that those people got second doses much earlier than we'd expected in our modelling. So what did we find? This is just an example graph looking at Fairfield and Campbelltown. And really what we found was that a targeted program would bring forward control by about 2 weeks, in the sense that we needed to get about another 30% reduction in transmission between about the 20th of August and, control, because RT was about 1.4 in our worst areas at that time. And doing the targeted program would bring this forward. And in bringing that forward, you greatly reduce your overall outbreak size and cumulative cases, and you also allow TTIQ to kind of continue functioning. Things might have been a lot worse if we hadn't done this. I guess in terms of how did this look from other sorts of data, so EpiNow2 is a tool for estimating the reproduction number in real time or near real time. And essentially the targeted vaccine program kind of occurred around this 16th of August point. And you could see that RT had trended up just before then in terms of potentially the lessening of control from TTIQ. But once that program ramped up and coverage across Sydney in general increased, we saw this sort of almost linear decline in RT down to values which are at the moment about 0.66 was what we estimated as of October 11 in a moderately tight range, and giving us some headroom for reopening. Now, our projections, and Nic will talk a bit more about this, do suggest continued declines with reopening, but I really want to stress this point. It's unlikely that we can predict RT to less than 20% error in terms of our forward projections at 4 weeks or whatever period you're talking about. And therefore the different sorts of predictions we've seen from different groups are all feasible, really. So the Burnett group is also working with New South Wales Health is suggesting a rise. Both are possible. Our results fall more to the line of continued decline, but you can't be too confident in these things. Just a note at the right here, Greater Sydney, well under control. The region's a little bit more a question at the moment, but RT is certainly median below 1 in the regions. So where we're going, I'm just going to try to wrap up as quick as I can. I guess you can kind of make the analogy to weather and climate with what we're doing. Short-term forecasts are really the sort of weather prediction aspect of this, and they really need weekly renewal, and the validity beyond a couple of weeks is in question. They can guide adjustment to controls, and I suppose the fact that RT is uncertain within this sort of 10 to 20% range is a problem, but it also means it's relatively amenable to changes in controls. So it's, you know, a problem, but also potentially solutions, you know, are raised by that sort of relatively small range of variation. The longer term scenarios, I guess, are around the need to guide bigger decisions. And I think the biggest sort of decision that's looming for us at a kind of a population level is what is the need for and timing of kind of booster doses in the general population? So I'm not talking about people who are at risk of serious disease, but for example, younger people, and, you know, questions about variants and vaccine escape come into these kinds of questions. I think some big remaining short-term questions where, you know, additional work is happening all the time at the moment are, you know, what's the relevant range of R0 values in Australia? Because we see differences obviously between what's happened in Sydney and Melbourne and what's happened in Brisbane. How much does this vary by location, density, climate, these sorts of factors? And I guess a specific one that a lot of us are somewhat anxious about, as well as maybe pleased about, schools are reopening more fully next week. What will the effect of school reopening have on transmission, given that we will have pretty high uptake of 1 and reasonable uptake of 2 doses in the 12 plus population? So I'm going to stop there. I've exceeded my time budget a little bit, but I'm hoping we're not going to be too bad here. And I'm going to pass over to Dr. Deb Cromer, who's a senior research fellow in the Kirby Institute, and she'll talk more about some of our work on mobility and its implications. Thank you.
So I am going to talk now about modelling movement during the current COVID-19 outbreak. What I have looked at here is, this is an overview of what I'm going to talk about, is I'm going to have a look at how movement changed in across Sydney in response to the cases that emerged in the current outbreak, or the most recent outbreak. We're going to look at how people's movement differed across different parts of Sydney. And finally, the modelling work, we're going to have a look at how the movement can be used, or maybe cannot be used, to predict case growth. Now, when I say movement, I just want to clarify what I mean here. There are a number of different records of how people move around that are made publicly available by both Facebook and Google. There are other metrics that are available, but these are the ones that I'm going to focus on at the moment. And basically, this has a look at all users of either Facebook or Google, and has a look at how they've moved around over time, and how that's the data that they've uploaded to Facebook or Google has changed. And they measure that compared to a baseline, a pre-COVID baseline. And so we can see how people's movement to going to work has changed, how much they stay at home, a whole lot of other things, how much they visit shops, they go to parks, etc., etc. And we can see how that changes over time. This is all aggregated and basically given by LGA. So we can really just have a look at relative changes over time. And that's what I've focused on here. So just also, I'm going to have a look at how movement changed over time. So in order to do that, I just want to have a quick reminder of the timings where things happened. So on the 16th of June, the first case was detected in a taxi driver or transporting someone transporting international arrivals. On the 23rd of June, so about a week later, there were the initial movement restrictions implemented for 6 inner city LGAs where most of the cases were occurring. And by the 26th of June, a light lockdown was introduced for Greater Sydney. So by light lockdown, I mean there was still retail opening, and there were restrictions on the numbers of people, but there were still, I think, up to 10 people allowed outdoors. So that was what we call a light lockdown. On the 9th of July, there was a tighter lockdown introduced. And then on the 19th of July, that was when construction work was paused, and there was a strict lockdown in place, and an even stricter lockdown in what the initial LGAs of concern. So all the work that I'm looking at is basically going to be having a look at movement over the end of June, July, and then into the first week of August, because that's when this work was all completed. So to begin with, I just want to have a look at how movement changed in response to cases. And I'd like to just spend a little bit of time having a look at this first figure that I'm going to show you, because there's a lot of figures that are going to follow that are all going to look fairly similar, and it's better if we can understand how to interpret them all. So in the what we want to see in the beginning is this is a map of Sydney. What I've highlighted outlined in blue, those are the LGAs where there was the initial cases, Waverley, Wallara and Randwick LGAs. And then in purple is the city of Sydney, because that was also involved in the early outbreak. What I've outlined in red, they are the LGAs that were initially considered to be LGAs of concern. So Liverpool, Canterbury, Bankstown and Fairfield. And then orange, this was at the time that we did this work, some other LGAs that had then been included in the LGAs of concern. Wasn't the final 12 LGAs, that expanded a little bit, but this was, while we were doing the analysis, these were the LGAs that were concerned. What we've got also is we colour in these LGAs according to how, what I've looked at here is the movement according to Facebook changed over time. Or actually has changed relative to baseline. So this was around the week that the first case emerged, and you can see everything's yellow. That means there was really no change from baseline, which is what we want. What we would expect to see around about the first case. Anything that goes slightly orange or redder means there's more movement, which we would hope not to see. And anything that goes greener or bluer means that there was less movement. And the more green and then going on to blue, you can see in the scale on the left, means that shows us how much less movement was seen. So once the restrictions were introduced into, this is the week that the first restrictions, the light restrictions were introduced and only into inner Sydney. And you see correspondingly, the blue and purple outlined areas are greener than the Western Sydney LGAs, because movement did stop due to those restrictions and probably also due to the cases. Then we have a look at what happened during a light lockdown, and we see that all again, the inner city LGAs are greener than the Western LGAs, but there is an increase a reduction in movement. And I want to say this is weekday movement, not weekend. So this is probably movement related to work and other things. But now we have a look at what happened during the strict lockdown, and you can see that the red outlined areas, sorry, that's disappeared, are really a lot bluer than the rest of Sydney. And the rest of Sydney is still quite green, showing a reduction in movement. We also had a look at weekend movement, because in some sense, the weekday movement is the movement that people need to do for work, school, childcare, general movement that is sort of almost, it's harder to stop. And then on the weekend, there might be more voluntary movement happening. So we can see in the week of the first case, there was already on the weekend, it seems, a slight reduction in movement in some LGAs, especially the blue and the purple outlined areas, compared to what they usually would have, so that people might have modified their movement even before restrictions were in place. Then on the weekend, there's already a strong restriction in all movement on the weekend, even when the restrictions were only in inner Sydney. Light lockdown, that continued. And then in the strict lockdown, you can really see that everywhere, especially in the west of Sydney and the southwest especially, is really had strongly reduced movement. So I guess the movement restrictions seem to be working, and there was an increase, a decrease in movement. The next thing we want to look at, so with that as a baseline, we wanted to compare how movement would have changed. So I'm just going to first of all look at going to work. Sorry, I've just jumped ahead here. I want to have a look at how movement changed across the different LGAs when people were going to work. Again, I want to spend a little bit of time talking about this slide, because we're going to have a look at more of them. So here, what we're showing is a graph, if you like, comparing all the areas of Sydney about how many of them had their movement reduced. So what we're showing here is Melbourne at the moment, and we're showing a graph, and we can see that pretty much all the LGAs in Melbourne had their restriction during their lockdown, had their going to work restrictions reduced by about 40%. They're going to work movement, because you can see at 1, we're down along an x-axis of about 40%. And basically how much these curves shift to the left of these graphs shows how effective the restrictions are and how much reduction in movement there is. What we've got here is the solid lines is for Metro Melbourne, and the dashed line is for outer Melbourne. Now, if we compare outer Sydney, on the left, we have the beginning of June, and on the right, we have the beginning of August. So you can see at the beginning of June, outer Sydney was going to work exactly the same as they were at baseline. They're basically all centered around 0 on the left, but by the beginning of August, their curve had shifted to the left, and so they were restricted. If we look at Greater Sydney, at baseline, so even in the beginning of June, there was slightly less going to work. You can see the purple line is to the left of 0 and to the left of the green line. But by the end of August, on the right-hand side, the people in Greater Sydney, most LGAs, were actually, their mobility going to work was even less than in Melbourne during their phase 4 lockdown. So we can see that comparing to Melbourne, that going to work had moved further to the left. And this was important because this is something that everyone wanted to understand was, were our restrictions having the desired effect? Were they having at least the same effect as the restrictions that happened that successfully squashed the Melbourne second wave? And so this is something that was really important to understand. And just having a look, though, interestingly, if we have a look at the red, which is the LGAs of concern, you can see that initially they had movement that was, they were going to work at an interim between outer Sydney and Greater Sydney. And also, once the restrictions were implemented, everything, they moved to the left, but not quite as much as Greater Sydney, indicating that people in those LGAs maybe still needed to go to work more. We can have a look at exactly this again, the same thing, but how much people I've called it not staying at home. So if they didn't stay at home, it means they moved around more. On the left-hand side, we have June, and we can see that everyone was at baseline across all the LGAs. And by the beginning of August, both the greater LGAs of concern and Greater Sydney had moved in line with Metro Melbourne, but the outer Sydney had not yet moved that far. And probably that is indicative of the fact that there were less cases there and there wasn't such strict restrictions there. So basically, the next step was to take all this information and try and feed it into a model to understand how cases were grown. And the bulk of this work was done by Eva Stadler, who's a postdoc in the infection analytics program. And she constructed a regression model to try to predict how fast cases were growing using both the number of cases in an LGA and the mobility variables, some of the ones I've discussed and some other ones, and including also a history of case growth, of cases and mobility in the previous weeks, because they might have impacted case growth currently. And the variables that she used in her analysis, I've listed them here, not to worry too much about them, but to say that they included cases in the current LGA, cases in surrounding LGAs, and then movement between them, movement according to Facebook, people staying put according to Facebook, people going to work according to Google, and then a combination of the two. So cases combined with how much people are moving around and all those things. That's the bottom variables. In addition to all the different variables, she looked at 6 different types of models. So models where all the data was included, and then going through subsets of the data were included. So models just in the 2 weeks after the first LGA, that's model 2. Model 3 was just at 3 and 4 were looking at whether case growth could be predicted in the very early, like when there was few cases, so less than 5 or less than 10 cases on average over the last week in the LGA. And models 5 and 6 were looking at models where there were large case numbers, so an average of more than 5 or more than 10 cases in the LGA over the previous week. And for each one, I won't get into details, I can if anyone's interested, but she tried 2 variations, a sort of just trying to find the best model with no restrictions, and then one that included some restrictions that maybe to us made a little bit more sense from a modelling point of view. But one thing that came out of her analysis, and I think is fairly obvious when you think about it, but maybe is also important to know, is that, and to keep an understanding of, is that when there are no cases, how much people move around is irrelevant to the case growth, because if there are no cases, you can move around all you want and there'll still be no cases. It doesn't matter how many people you come into contact with. So in some LGAs where there are no cases and very little movement between LGAs where there are cases, the movement doesn't have much of an impact on cases and therefore is not important to the model. On the other hand, when there are cases, there's, if you like, a bidirectional relationship between cases and movement. So if there are already cases present, when movement increases, then case numbers increase subsequently because you have more movement, you have more interactions, and then you have more spread. But of course, when case numbers increase, then movement decreases. Partly because restrictions get put into place, but partly because people tend not to move around nearly as much when there are high cases in their areas. And so you see this dual relationship, which is kind of why we needed to split up the model. So then a summary of what we saw. Now I'm going to show you a whole lot of things. Suffice to say, if there's nothing, no square present, it means that variable was not important in the model. If there is a green square, it means that variable had a positive impact on case growth, so it increased case numbers. And if there's an orange square, it means that variable decreased case numbers. But I'm going to work through this, but that's just what we want to keep in mind as we are. We've got the models 1 through to 6 at the top, just like I explained before, with the left-hand side kind of representing low case numbers and the right more presenting high case numbers. The first one's obviously all the data. Oops. So the first observation is that at low case numbers, moving around combined with cases in an LGA increases case growth in the following week. So we can see that by these rectangles that I've highlighted in pink, where there's a green box when we combine case numbers and movement, or case numbers and not staying put. So kind of the same thing. So you see green there. However, at high case numbers, the actual number of cases become less relevant, which we can see by the dashed boxes. So at the bottom, we see that there's no green squares at the bottom, but at the 2 dashed ones at the top, where we just take movement and not staying put into account, irrelevant, not combining them with case numbers, they are important. So when you've got high case numbers, really just any sort of moving around is important. But at lower numbers, you need to combine the number of cases with the movement. And again, that seems to make quite good sense. On the other hand, and now in terms of work, once again, we see at low numbers, cases in an LGA and going to work increases case numbers in the following week. But at high case numbers, again, the number of cases themselves become irrelevant. No green boxes down the bottom, but the going to work does become important. Finally, second last point, cases in a surrounding LGA, and movement between the LGAs are important in predicting case growth at all levels. So what we've got here is green all across the area where you see cases in surrounding LGAs combined with movement between them. So that's always important. And finally, and this is a caveat, well, two caveats I should make. One I've highlighted here. None of the models were a particularly good predictor of case growth. Down the bottom here, we've got the amount of variance that our model was able to explain. And basically using all these, we could at most predict sort of 20% of the variation in the growth of cases. So there are a lot of other factors that are going on here. But I think that's clear because there is a bidirectional relationship, and there's also a varying impact of restrictions. So as case numbers increase, restrictions get put in place. And so from a modelling point of view, it's quite challenging to capture all of that in one model. But there was a lot of modelling, and as I said, this is all Eva's done, the bulk of all this modelling, and I think the results that came out were both intuitive and also quite interesting. I guess for completeness, I should comment on the fact that we put in vaccination into the model. That's variable 4, but we didn't see an impact of that. The reason for that is clear. This was in July and August that we were modelling this, and the vaccination levels really hadn't changed that much at the point that we were doing the modelling. And so I don't think that's at all indicative of the impact of vaccination. It's just that it was very early stages and there wasn't a lot of variation in vaccination. So it didn't really change the model too much. So that's pretty much a summary of the movement modelling that was done. So to summarise, the movement across Sydney did change in response to increasing case numbers and increased restrictions. At the height of the lockdown, the changes in movements were fairly similar to the changes in Melbourne's second wave. So we did get there with the restrictions that were in place. But there is a change in the relationship between movement and case growth as case numbers increase. And again, that is intuitive, but it does mean that just reducing movement once there are already high cases, it has some of that is going to not be as intuitive as you would think. So as I've said, there is some relationship between the two, but it does change over time and depends on restrictions and case numbers. So with that, I will hand over to Nic to share his presentation. Thank you.
Okay, thanks for that, Deb. So I'm going to talk through some of the, I'm going to talk through the agent-based model that we've used for the predictions we've been doing for New South Wales Health. I'll start with a little bit of background to the model. Public health orders have clearly been central to controlling COVID-19 transmission. We've seen this in New South Wales in the form of regional stay-at-home orders and restrictions placed on individual location types and industries. So, for example, one of the main restrictions that we've seen quite a bit during COVID-19 has been limitations placed on hospitality venues, in particular limiting dining-in capacity and also placing restrictions on mask use, around mask use. During the Delta wave, we've also seen industry-specific rules around which industries are allowed to go to work and which ones aren't. So one of the main issues with these restrictions is that we don't actually have quantification of their direct effect on transmission. So some restrictions may be more likely than others to prevent large transmission events, but we don't have data to say exactly which one's which. So this information is quite important to policymakers as well, because when they're actually making these decisions, they have to weigh the cost in onward transmission against what the economic cost of some of these restrictions are going to be. So contact tracing data collected by New South Wales Health does provide some insight to this problem. And so what I've graphed here is pre-Delta data for Sydney, which shows the number of transmissions per contact event, and that's being grouped into the setting of the event. So, for example, I've got general hospitality locations up at the top, and hospitals and retail shops and so forth as the different settings of transmission. And what we can see is, or what we can do with this graph is, we can simply look at which location classifications have a higher propensity for larger transmission events to get a sense of which industries might make sense to target with restrictions. And under that sort of understanding, we would say, okay, places of worship and hospitality venues make sense to target. But one of the problems here is that there's a number of complications to this data that are not immediately clear. So, for example, case and contact ascertainment rates do vary between the different types of locations and also over time. So, for example, this can occur if the public health officials have quite a high workload and they're just simply not able to identify all of the close contacts for a specific location. And then also QR code use for the location will affect the number of close contacts that they're able to identify for a location, and consequently may also be an issue for identifying the number of transmissions that actually occurred at a location. In addition to this, we also have this data was collected over a period of time with varying restrictions, such as location capacities. And that has the propensity to make some locations appear less likely to see transmission than they really would be. So you can see quite low down on this list, we have office buildings primarily not having very many transmission events, but we know that if we did open up, then office buildings would actually be of a very high risk of seeing transmission events just from the epidemiology of the disease. So that sort of gets us to the original question of this model that we developed for this work, which is, are we able to account for known uncertainties and biases in this data and try to estimate the direct effect of some of the individual restrictions that were placed pre-Delta? So can we use this information to sort of drive a list that says which restrictions are going to be more effective than others on onward transmission? So I guess the first question is, what sort of model would actually be able to do this? Well, from looking at the data, what we have is that roughly half of all transmission occurs within households, and then workplace and community transmission each account for about a quarter of transmission. In addition, from sort of reconstructing sort of the linked information, which sort of suggests who infected who, and getting a sense of where the transmissions occurred, what we can actually see is that if contact tracing is quick enough to pick up a household with a newly infected individual before they're able to go on and transmit more infections, then that's generally very effective at stopping the spread of the infection. And so that's one of the main things we saw with the Delta strain, is that we had some large households around the start, which caused a lot of ongoing trains of transmission, which were difficult to get under control once they'd gotten out. So what we wanted to do here is develop a transmission model, which is really a between household transmission model, and where infections are spread from household to household through common mixing locations such as workplaces and community locations. In modeling it this way, what we're able to do is to change features relative to transmission for these different exposure locations, such as workplaces and community locations, and then simulate the overall effect on ongoing transmission. So what I'm going to do now is I'm going to step through this little schematic here that I have on the right-hand side of the graph, which effectively just sort of summarizes how transmission occurs in this model. So the fundamental units of the model are the individuals, of course. And what we wanted to do with these individuals is to give them realistic working and social patterns, patterns of work and social activities. So what we do there is we start by assigning them just a number of simple attributes which are relevant to these sorts of behaviors. So what we do is we've used ABS data to assign simply an age, a gender, and an LGA of residence. And that's because a lot of the mobility data that Deb was talking about is available by LGA of residence, or LGA, and then also just ABS data by age, gender, and LGA is also quite easy to get a hold of, at least for the 2016 census. So then once we've given them these features, age, gender, and LGA, we also give them a workplace. And we do this again using ABS employment data. And we characterize those workplaces by the ABS 2-digit industry codes. So to give you a sense of sort of what that looks like, there's one 2-digit industry code which summarizes all food and hospitality beverage locations. to give you a sense of what that looks like. And then additionally, once we've given them a industry of employment, we also give that workplace an LGA using ABS Journey to Work data. So we have a sense of, per LGA, what are the different work distributions and what are realistic patterns of commuting from home to work by industry. And then what we do is we obviously assign them an infection status. So you see in this graph here, I have that individuals are either susceptible to infection, they're infected pre-onset, they're infected post-onset, or they've been removed from the infectious class for whatever reason. So then moving on to exposure locations, what we have here is individuals are able to transmit infection when they visit either a workplace or a community location. So I mentioned that we give them workplaces in the previous graph. Obviously, they can go to work. That occurs with different probabilities depending on which industry they're employed in, but they can also go to community locations. And they can also go to multiple community locations in the same day. These two different types of locations vary by the probability of transmission at either location, and that's because workplaces typically represent a longer exposure time, and so there's therefore a higher probability of transmission compared to just a community location. They also have a number of other differing attributes. So, for example, workplace. Well, all locations have a set capacity of workers. And that means that they have a set number of workers there, and the population of those workers is fixed. But when they go to community locations, every time there could be a new number of people that they run into there, and their attributes change every single time. And then clearly, every time that there is a transmission, we generate a new household, and the chain of transmission continues. So to quantify actually how is infection actually, or how is transmission actually quantified in the model? We have a probability of transmission from one infectious individual to another susceptible individual, and that depends on quite a number of different things relevant to the source case and the susceptible individual. So I've just sort of written out the equation here and numbered each of the different components so I can sort of break it down and mention what each of them are and what's their relevance. So I guess to sort of summarize this very quickly, we have a differing baseline transmission probability depending on the risk of the location. So that's it's highest for households, it's slightly lower for workplaces, and then it's lowest for community locations. We then have differing likelihoods of onward transmission depending on the vaccination status of the source case, and also differing levels of susceptibility of the secondary case depending on what their vaccination status is. So which dose of vaccine have they received, which vaccine have they received, how long since their last vaccination. So most of the components of this model we can inform through research, but this PL, so the baseline probability of transmission per location, needs to be calibrated to the data that we have, because we don't have anything else to inform that really. So I'll also talk briefly about what are the different ways of quantifying public health and social measures within the model. So there's a component of the model which describes basically the New South Wales Health response to infectious individuals. So that is contact tracing. So what we've done is we've used this data from New South Wales Health to work out what are realistic delays between the time from isolation to test to result to interview and to when their secondary cases are found. And these change dynamically depending on which stage of the outbreak we're at. And we also have non-pharmaceutical interventions. So these are largely just changes in mobility. So we have the proportion of people staying at home has obviously changed quite a bit during the outbreak. So we use sort of the full time series of that information to change what proportion of people are staying at home. And we do a similar thing for work, and also the number of contacts made per person per day, given that they leave the home. We then also have industry-based restrictions, obviously, because this was one of the main features of the model I mentioned at the start. But the big part of this is vaccination. So vaccination coverage has obviously changed over the Delta outbreak quite a bit by age group and also by LGA. And to give you a sense of that, on the right-hand side here, I just have a graph which shows the proportion of 20 to 25-year-olds that have received a first dose of Pfizer, first dose of AstraZeneca, and also a second dose of those two as well. And so you can see in this grayed out area, which is when there was the very targeted and rapid uptake of vaccinations, especially in LGAs of concern, there was a huge increase in number of first doses, or the proportion of people with a first dose in an LGA of concern. So that's a very important input to the model. So what we've done with that information is using all those dynamic inputs and these and also these attributes of disease transmission, we've tried to estimate what these baseline transmission probabilities that I mentioned actually have to be in order to get a realistic match to the data. And what we can see here is on the top row here, we have the overall number of transmissions per day. And on the right-hand side, this is by the onset date of the case. And the dots here show the actual observed incident, the actual observed case series. And the blue lines show simulated outputs from the model, with the mean of these simulations shown in red. So we have a good overall fit to the curve. And we get this nice turnaround here, which occurred in the face of rising numbers of vaccination. This is still a bit of work in progress, though, because the model is really sensitive to different transmission probabilities. Yeah, well, okay, yeah. So more or less, forecasting reopening, we're just predicting that mobility will return back to the levels that it was before the outbreak. Is sort of the base assumption there. And what we see as a result of that, using the parameters that we got from the calibration, is that case numbers are likely to continue to decrease, but not quite likely to go to zero. And now back over to John.
Apologies again to Nic, and clearly his presentation generated a huge amount of interest and probably worth a whole seminar in itself. And I think we'll give him that opportunity again as the information from this very complex and sophisticated model starts to unfold. So we're now very privileged to be joined by three discussants. From the University of Melbourne, we have James McCaw, Professor James McCaw, and Dr. Freya Shearer. Both of them have been working at a very high level in the national response, sometimes collectively referred to as the Doherty modelling team, but I think everyone understands that there's people from all over the country who have been involved. James and Freya are both associated with the School of Population and Global Health and the School of Mathematics and Statistics at the University of Melbourne. And then the third discussant we have is Andrew Wilson. Andrew's primary role is with the University of Sydney as the head of Menzies Centre for Health Policy, but he has many other roles. He has been a past Chief Health Officer of New South Wales. He's also the chair of the Pharmaceutical Benefits Advisory Committee. And currently he's actually working with the current Chief Health Officer, Dr. Kerry Chant, on it as a senior advisor. So I might ask each of them in turn to reflect for about 5 minutes on what they've heard, but also the bigger picture of how modelling has fitted into the way that they've understood their roles in responding to the pandemic in Australia. Over to you, James, then Freya, then Andrew. Thank you.
So thanks for the opportunity to make some comments. So for the last 15 years, I've been working ever since I moved into the field of infectious disease epidemiology. I've been working on pandemic preparedness and response, really stemming from early initiatives following SARS about the Australian government's identified need to be prepared for pandemic pandemics from one virus or another. And that's some work that, where I first met James Wood as well, working in similar roles. And so, and that was along with Professor Jodie McVernon, who many of you will know that name. And so in 2020, early on, when news first came up about a potential pandemic pathogen, it just turns out that I was part of a, WHO forecasting and situational response group, and was invited to a meeting and heard some early reports out of Wuhan, and then was invited to brief the Australian Health Protection Principal Committee. This is about the 16th or so of January 2020. And it's important and interesting to think back to that time, because actually the first question I was asked as a disease modeler, and it was unclear at the time, was whether or not this was a contagious pathogen. We now know it certainly was, but it took a good week or two, about a week, for the international community to settle on whether or not this was actually spreading from human to human, or if it was simply a zoonotic source and a dead end, so an exposure within the markets in Wuhan. And so what very quickly developed was my role, and Jodie McVernon and Alan Cheng are the two other invited experts on AHPPC, supporting the Chief Health Officers and the Chief Medical Officer of Australia. We were there and remain there as people to provide advice on infectious disease epidemiological, that insight from ID-EPI. And in particular, for me at least, also model-based insights. And so we've worked through a lot over the last 18 months, and some really fundamentally important things I think that stick in my mind that I think are relevant to this day are ideas like early epidemic growth in a region the virus doesn't know how big the population it's spreading in. And so we should be thinking particularly early on about raw case counts as opposed to per capita values. That was very important early on, and it remains incredibly important when we're looking at, say, hospital system capacity, because the larger jurisdictions inherently are going to be more capable because of the different relationship between epidemic growth and hospital, ward beds and occupancy, which normally scale per capita, but the virus spread, at least initially, does not. That's a very complicated thing there when you dig further, as I think we've seen from some of the talks. There are different spatial effects. So concepts like that are, a big part of the role I've played in helping the Chief Health Officers, who are clearly absolute leaders and experts in health, but only some of them have got an epidemiology or indeed an infectious diseases background or infectious disease epidemiology background. They've all had 18 months now, and I think are almost experts in that field, but they certainly didn't come starting at that point. So then the other thing I'd just say is that, and Freya might build into this more, is Australia was put in a very interesting position in terms of the needs of modelling and the development of new methods, because we did a lot of scenario work early on to help identify that this was a genuine threat. That work was completed by the 3rd of February 2020, essentially, or initiated on late January and finished in the first week of February or so, to identify there was a genuine threat here and we needed to be prepared to respond. Then, of course, the virus came in. We used things like real-time estimation of effective reproduction numbers and things to try and understand what might be, how it was spreading and how we might respond. Models, helped us support early closure of the international borders and then management through the quarantine facility, which, despite some of its clear failings, has been also a success story with clear rooms for improvement. And then we eliminated the virus, or we eradicated the virus from Australia for quite a period of time. And that really drove the need for some new methods around mobility patterns and risk assessment to know how Australians' choices of how they were moving and interacting in society may modify the risk of the virus re-establishing itself in Australia and then spreading through the community. And that prompted a lot of methodological work. We've just heard from James and Deb. They've referred a couple of times to the transmission potential, which is indeed a concept that with Freya, Nic Golding invented early last year to help us understand the not unique, but lucky position Australia was in, along with a few other countries, where we needed to monitor what the virus might do if it was here, but thankfully it wasn't here. So look, I've just given a very high level sort of discussion about what my role's been. I'll say one more thing, John, before handing over, which is that I still think there's a long way to go in Australia for us to better differentiate between forecasts, and which is like the weather analogy that James Wood discussed, and scenarios, which are the climate analogy there. When those two ideas, which are distinct roles for mathematics and analytics, are conflated, we come up with confusing positions or discussions or debates possibly in the media, which don't necessarily make a lot of sense. So there's more work there to be done from people like me and other people on this call about explaining the difference between forecasts and scenarios, I think. And that will become more and more important as the virus becomes established in our country. Thanks, John.
Thank you, James. Over to you, Freya.
Thanks, John and James, and hi, everyone. So I can be quite brief because James has touched on, James McCaw has touched on a few of the things that I was going to say. So John asked me specifically maybe to comment on some of the data streams and data needs that have been important for informing COVID modelling. And the one that I wanted to highlight was population level behavioural data, which all three speakers talked about in terms, like talking mostly about mobility data. And that's been really important for COVID modelling around the world because we've most countries have implemented response measures that have been reliant on people changing their behaviours, and being able to measure how people respond to those policies and how much behaviour has changed has been important. And that's been particularly important in Australia for the reason that James McCaw just touched on, because we found ourselves in a situation in April 2020 where we'd driven the case counts to really low levels in most jurisdictions, and the virus was still a threat. And having an understanding of risk, what would be the expected transmissibility of the virus if it was introduced back into our population, from understanding how people have been moving around and interacting was really important. So, so we've been fortunate to have access to mobility data from which has been made available by technology companies, but also there's been, and not just in Australia, but lots of other places around the world, anonymous behavioural surveys asking people directly how many contacts they've had in the previous 24-hour period, and other behaviours that help to reduce the probability of transmission when you do interact with people, like adherence to the 1.5 metre rule and frequency of hand washing. And we've used all of that. We use all of that information on a weekly basis to estimate the transmission potential. And then when we have cases, we also estimate the effective reproduction number, and we can look at both of those bits of information to tell us different things about the epidemic dynamics at any given point in time. So, and you would have seen James Wood talking about both of those metrics in his presentation. I think I can probably stop there. I know there's been lots of questions as well. So,
well, if we have some time, we'll come back to some of those points in discussion. But now, thanks, Freya, and we'll hand over to Andrew to give us some insight into what took place inside the corridors of power as the modelling results came through and were cogitated upon.
So, John, I may move in mysterious circles, but not necessarily the corridors of power. So a couple of things I just wanted to comment on. There's a comment right at the start of the questions there about whether or not some of the modelling was political in nature or influenced by politics and why people read it. Look, I won't speak for all the modelers, but all the ones that we work with, that is not their business. They're not in that side of involved in those sorts of things. But inherently, when you're making decisions which have impacts on people's lives in the way that we have done to try and control COVID, I mean, basically mandating vaccination, essentially requiring people to stay at home, imposing curfews. These sorts of social measures are inherently political. They have political ramifications, they have economic ramifications, and they have enormously disturbing implications for families and people in terms of schooling, work, etc. So, there is an element to which the interpretation and action on any of these things that we do, there is an element, if you like, in the broader sense, political. Another comment there was around, there are many models. Do we need that many models, etc. And this is a question I've asked myself, not just in the context of this, but in the sort of area which I'm more familiar with normally, which is in the area of chronic disease, where modelling is also increasingly playing a role in decision making in relation to it. And the answer is, if we thought we had a perfect model, then of course we wouldn't need it. But we don't, because we don't even know what a perfect model is until after the event. And so what I've found extremely useful and extremely interesting being involved over the last couple of months in New South Wales Health and with the different modelling groups is the different ways of looking at similar questions or even the same question, trying to understand when there are differences, why those differences are occurring, and then trying to understand the implications of that for the decision-making process. And then the last comment I just make is the Delta, observing the Delta outbreak more closely as I've been able to do. So for the last few weeks, just about every day, we would sit down and review what was happening across New South Wales, looking at where cases were developing, particularly in the regions. It became very apparent that the transmission of this virus is not occurring in a sort of straightforward linear way that we would associate with widespread epidemics. We're seeing particular transmissions between particular social networks, between particular households and extended household networks. And this question of the heterogeneity of spread has been a really important one, and one that the modelling groups have also attempted to have a look at and see what the implications of some of that heterogeneity is in terms of predicting what might be happening in future. And that's really been a very fascinating part of this process. I'll leave it there, John.
Thank you, Andrew. And so we do have now 10 minutes to open up into a bit more general discussion. And I wanted to raise with the modelers, maybe starting with James at the national level and James at the New South Wales level, the issue about access to data. And do you think that the processes of providing access to data need to be further strengthened in our context? And that's one question. How do we make sure those data streams are available to the modelers? And secondly, I'll actually bring Freya into this one as well, because you referred to the behavioural data, which is so important. But how do we also democratise the process, or how much should we democratise the process so that anybody who's interested in doing some modelling can get access to the same data sets that the other modelers are using? Should modelling be a constrained process with restricted to groups anointed by the government, or should it be more open slather? And I might just ask all three of you for the comments on that.
Sure. So thanks, John. So my view as a scientist, which is what I am, is that the more the data is open, the better. And I have advocated actually internally within the government, given the relationship I've got now and the opportunities I've had, for there to be more openness on both the availability of data and indeed on the public reporting of the modelling that goes to governments at all levels. And I think in general, that is just going to be helpful. I'm going to just caveat that with two statements. One is data availability in Australia is tangled up with our federated system. And so while I have that view as a scientist, I'm not suggesting there's a simple solution. So I don't think it's as easy as some people might think for that to be resolved, but in principle, I think more can be done for data to be more available in appropriately de-identified ways that protect individuals' privacy. And of course, on the output side, so the insight from modelling and the role that modelling plays in supporting decisions that are made by governments. Of course, modelling and modellers have not made a single decision during this pandemic. That should be public, and it should be coming out in the peer-reviewed literature in due course. I would note then there are some aspects of that where it is very helpful for people working with government to support their decisions to be able to provide certain, ways of framing or interpreting their own work. Providing that in a confidential way to government can assist in government making decisions. But I think when it comes to the actual science of what was done, the more open that is, the better. And I think that there's a complicated relationship there between the desires of government and the desires of the scientists, and it comes with the territory of working in this space, that there are some inherent tensions there for academics and scholars and scientists.
Freya, as a little bit earlier career person, has this work, do you think, enhanced or inhibited your academic output?
Probably a bit of both. I would say you hope that it overall enhances your academic output, but I think what we consider academic output is probably maybe supporting government is not always highly valued, and so then that would be one way in which it is sort of harms or prevents you producing what's considered an academic output. So yes, I think in a very traditional sense, I haven't produced much academic output in the last 2 years.
But you've served the nation well. James Wood and Deborah, in working with New South Wales Health, do you feel that you had access to the data you needed to have access to, and do you feel that it was reasonable for you to have that access when perhaps others didn't?
John, maybe I'll go first. So just a quick comparison. When we started doing pandemic planning 16 years ago, there was zero data at all. In the 2009 swine flu pandemic, there was basically zero data unless you had an MAE student sitting in a health department who could feed you Excel spreadsheets. And this time is the first time really there has been provision of real-time data sets that are actually, and that has evolved throughout the pandemic. I feel like, we've had excellent support from New South Wales Health, particularly in this contract period, in terms of the amount of data we've been able to get access to. And some of that has been development of our own processes throughout. In terms of the open sort of data question, look, I think the more people who have access to this data in the long run will be better. I think there are some concerns in sort of the immediate decision-making frame, and even time allocation questions about, even just providing data sets is taking time away from some other urgent response, which is difficult. But, I do really want to see some learnings from this applied in kind of future about how we provide these resources more easily, more readily, and while protecting privacy to the various groups involved.
Yeah, I mean, I guess I'd echo on with that, but I think it's important also to keep in mind that this is a new situation for everyone, and the health departments as much as anyone. So a lot of the time there's a lot of willingness to provide the data, but the actual implementation of the data and provision of the data in a format that would be useful and interpretable it just has challenges necessarily, because it's constantly evolving, and there is an understandable reticence in providing data that may not be complete, that may not have been fully curated. And so that's been something that has been an ongoing issue for New South Wales Health and other health departments along the way through. And we've developed a good relationship, I think, now, and so have been privileged to be able to have access to some data prior to it being fully cleaned or in the exact format that they might like to have it in before they release it. But I think there are some understandable reluctance in making data that may be changing over time, because there were, data entry, mismatches or for various reasons, making that completely publicly available. And I think that's probably sound as well. So there is a balance in, as James said, investing the time and curating the data and making very good data publicly available, or like later, or providing sort of messy data earlier on. And I don't think it's a clear answer about what to do there.
And they were the things I was hinting at as well.
Might just ask Andrew for the last comment from the perspective of sitting inside as you are for the health department. How do you view this question of data sovereignty and access to data by individuals who may be interested but may not be inside the tent, as someone put it in one of the questions?
Yeah, so John, the public health researcher side of me would welcome a more open access to data, encouraging more people to test different models, etc. The pragmatic one side of me, based on experience of working with governments and working with using models to influence government, is people have to trust what could come out of it. It's a process of actually engagement with government that's involved in it. And the modelling groups that are involved with New South Wales, and for that matter, the broader Doherty group at a national level, are involved in very close dialogue with governments on an ongoing basis, and that's part of forming that trust. And part of that trust is that government wants to know that the people that are involved in the process are appropriately endorsed, appropriately qualified as part of it. So again, it's not totally surprising to me that they might have a limited number of parties that they're going to sort of fund and prioritise in that process for that.
Okay, well, we've just reached time. When we proposed this seminar, we were told that it was ambitious to try to do all this in an hour and a half, and there's clearly many interesting strands to this conversation, and apologies to the number of technical questions that have been put forward in the chat and in the Q&A. I'm sure that the modelers and all the discussants here would be pleased to engage with anybody here. But I also have the impression that this is, I think, the start of a very useful longer term discussion at a state and national level about how modelling fits in, how we do all the things that we need to do as well as possible, and create opportunities to strengthen the linkage between academia and government policy making. So thanks again to our three presenters and our three discussants, and thanks everyone for joining what I think has been a fascinating session.
Thanks all.
Thanks, John. Thanks, everyone.